This is the 8th and final module. It is going to be about the procedures to measure the median nerve and assess for carpal tunnel syndrome. Upon completion of this module, the student will be able to understand the procedures necessary to capture an optimal ultrasound image of the median nerve. We'll be able to measure the cross-sectional area of the median nerve at the carpal tunnel and pronator quadratus. We'll be able to synthesize the information from the ultrasound examination and compare it to other diagnostic measures of carpal tunnel syndrome. And we'll be able to understand reasons why ultrasound is a reasonable alternative to MRI, especially in the clinical setting for a physical therapist. So what are we looking for? Any obvious abnormalities or pathologies within the carpal tunnel or the surrounding area. Example, bifid median nerve, abnormal branches, ganglion cyst, edema, or an abnormally large median nerve. Obtain the cross-sectional area of the median nerve at both the level of the carpal tunnel and the pronator quadratus, and then calculate the change in the cross-sectional area between the two locations. So the patient is going to be positioned seated with the elbow extended and forearm in supination. They may need a pillow under the shoulder to make the patient more comfortable. And basically, you're going to measure the cross-sectional area of the median nerve at the 2 points and then do basic subtraction to find the difference and look at the diagnostic measures to see if that is abnormal or if it's normal. We're going to talk about measuring the median nerve now. On the ultrasound machine, you're going to identify the median nerve on the ultrasound image. So at the carpal tunnel, remember it's going to be superficial, and then once you get to the pronator quadratus, it's going to be a little bit deeper. Make sure that the focus is set so the arrowhead is located at the depth of the nerve. Remember, so we don't get any artifacts. Does maneuvering the transducer make the image more clear? So kind of play around with that. Make sure you're getting the best image possible. Is the depth and brightness optimal for viewing the median nerve? And again, you only care about seeing the median nerve when preparing to measure it. So don't worry about any of the other structures because that is your target structure. So you want to make sure that everything is set to optimally view the median nerve. Keeping the transducer as still as possible, you're going to press the snowflake button on the control panel to freeze the image. And I have it right here, circled in red. It just looks like a snowflake. And just as a note, we're using a MyLab Sigma, and the transducer is going to be L4 through 15, which that's the frequency. The next step is using the control panel. You can add annotations to the image. We usually put an M on the median nerve so that when we went back to the image, we knew what we were looking at. So you can label anything that you need. You can label whether the image is the left or the right hand or at the carpal tunnel or pronator quadratus so that you don't get confused later on. Then you're going to press the trace button right here that's circled down here, and then the area tab, which is the circle up here. After you've done that, you can trace inside the hyperechoic edges of the nerve. You are going to find the cross-sectional area of the median nerve. It's just going to pop up on the screen. You're going to find that at the carpal tunnel and the pronator quadratus. So this will give you CSA-C and CSA-P. Then you will use these to subtract these measurements to find the difference in the cross-sectional areas. You should also look for any other abnormalities or pathological conditions during your examination, and we're going to talk about those later. Here's an overview slide, and I prepared a video of us tracing the nerve as well. So first, you're going to identify the median nerve, prepare the optimal image, whether that's moving the transducer, changing the depth, changing the focus, brightness, whatever you need to do. Press the snowflake to freeze. Make any necessary annotations to either label the nerve or the image itself. Press the trace button, press the area tab. You're going to get to the nerve and trace the median nerve inside the hypercoic edges, and then the ultrasound machine will give you the cross-sectional area. So let us watch this video. He presses the trace, then he clicks when he gets the nerve and he's tracing around it. He's doing this pretty fast, but he's had some practice. So once he gets around the nerve, he's going to click again, and then the machine gives us the area. So it's a 0.11. And to the right of the video, we have just a traced median nerve example, so how it's going to kind of look close up. I'm going to let you guys watch the image one more time. So he presses the trace and then the area tab, he clicks, and then using the ball, he's going to go and trace around the median nerve. Inside the hyperechoic edges. Once he gets around, he'll click again, and the machine gives you the area. Now, you're doing all of this work. What's the point? How are we assessing for carpal tunnel syndrome? The best diagnostic discrimination of carpal tunnel syndrome is achieved by using the optimal threshold of a difference between the cross-sectional area of the carpal tunnel and the pronator quadratus of greater than 2 millimeters squared. Comparing the nerve's cross-sectional area obtained at the carpal tunnel with a measurement obtained at a more proximal level, pronator quadratus at this point, has a sensitivity of 99% and a specificity of 100%. Another measurement is the cross-sectional area of the median nerve at just the level of the carpal tunnel. So the cross-sectional area of 11 millimeters squared, that threshold has a sensitivity of 99% and a specificity of 86%. When you go and move it up to 12 millimeters squared as your threshold, that has a sensitivity of 94% and a specificity of 95%. Even though we just talked about all of these different thresholds for diagnosing carpal tunnel syndrome using real-time ultrasound, we need to always synthesize the information from the whole examination of the patient. We don't want to just take one part of the puzzle piece. So we need to take subjective, objective, special tests, ultrasound imaging, all of these together to diagnose the presence of carpal tunnel syndrome. Some of the special tests we did was Tenel-Sign, which has a sensitivity ranging from 23 to 67% and a specificity ranging from 55 to 100%. We chose reverse Phalen's over Phalen's, even though it has a specificity and sensitivity that are not well studied. But the average change in pressure after 1 minute of reverse Phalen's compared to Phalen's was 34 millimeters of mercury versus 4 millimeters of mercury, respectively. So we thought that we would take reverse Phalen's and use that because the pressure on the median nerve was so much greater. Other assessments include carpal tunnel syndrome outcome measures that Christina talked about and sensory testing as well. Finally, these are the top 10 reasons why MSK ultrasound is a good alternative for MRI. One, there's less contraindications for patients. They're more able to undergo this ultrasound. High-frequency ultrasound can detect tiny abnormalities that simply can't be shown by standard clinical MRI techniques. It allows real-time dynamic examination of the patient. You can move their hand. You can apply pressure. You can take away pressure. You can do this while they're in different positions. It's just very flexible in the dynamic aspect of clinical examination. The ultrasound probe can be placed exactly on the target tissue that needs to be examined, and you can make sure that there are no artifacts and that the transducer is perpendicular to the tissue that you're trying to view, and you can also make sure that the depth and everything is correct. Ultrasound can effectively image patients with surgical hardware. Doppler ultrasound, our ultrasound is a Doppler ultrasound, but we didn't really go over that much, but it can provide important information regarding blood flow. Ultrasound is better at differentiating fluid from solid material. Again, you went over this in the previous modules. Ultrasound facilitated bilateral comparison. You can easily compare the right to the left when doing ultrasound. Ultrasound has a more flexible field of view. Again, you can change the depth. You can easily change from longitudinal to cross-sectional views. And most importantly, PTs can use MSK in the clinic. Ultrasound is better at guiding therapeutic interventions. So although MRI remains the imaging preference standard for a wide range of MSK disorders, MSK ultrasound is an important technique and alternative to MRI, especially for physical therapists in the clinic. Here are some references, and it's time to take your last module quiz. So if you could go to the module quiz tab on the website, and you are done. Thank you so much for listening to this whole educational program, and we look forward to seeing you during the lab practical portion of this educational program. Thank you so much.